This is a story of 1992 when Dr. Hanjo was sitting in his laboratory and observing under microscope. He has kept 3 cells on his slide. So on his slide there were 3 cells. One was T cell and one was healthy cell, one was animal cell. So he had taken these T cells and this healthy cell. Healthy cell means there was liver cell, hepatocytes, from the healthy person. From the same individual, this T cell and healthy cell was taken, and this liver cell was from animal. So it was foreign. So what he observed, that this T cell killed this foreign cell, but it did not kill the healthy cell. So you might be thinking that there is no brainer in saying that T cells kills foreign cells and it does not kills its own cells, healthy cells. So what is the new thing in that? But for this concept he won the Nobel Prize. So what he actually observed, that T cell expresses PD called programmed death on its surface. This is receptor, and when it interacts with PD ligand on a healthy cell, then when there is interaction of this, then it recognizes that it is my self cell, so I should not kill it. But let's suppose there is foreign cell, so it does not express that PD ligand. There is no expression of this, so it kills that cells. Like this, at this time there are some cancer cells growing in my body. Let's say in my liver there is some new cancer cells, but this is killed by T cells. So that's why I don't have developed cancer, because constantly due to some certain toxins or some insults there is mutations going on inside the body, and cancer arises after cancerous cells arises with that, but that does not express the PD ligand. That's why the T cell recognizes that it is foreign and it kills that. That's why we do not develop cancer. But some cancer cell becomes clever, so it thinks that, oh, if I express PD ligand, these T cells will not kill me. So some cancer cell express PD ligand, and then the T cells gets pulled and it won't kill, and that cancer cell goes on producing its sons, daughters, grandson, granddaughter, grandson, and goes on multiplying and makes the whole cancer. So let's understand this in simple terms. This T cell is circulating in your blood. This T lymphocyte, some is in spleen, some is in lymph node, some are circulating in the blood all time and doing the job of policeman. Wherever it encounters the foreign antigens, foreign cells, it kills that cells, or cancer cells that it recognizes that it is not myself, it kills that cells. So let's suppose this cell is circulating in your blood and it encounters your hepatocytes. So it tells the hepatocyte, show me your ID card. So the hepatocyte says that I have this ID card, PD ligand. So it says that, oh, then okay, you are fine, I won't kill you. But let's suppose there is one cancer cell. Then it does not, it says this cancer cell, show me your ID card, but it does not have PD ligand, so it directly shoots it and it gets killed. So cancer cells or foreign cells are killed by T cells because they don't express PD ligand. But I told that some cancer cells evades this by producing PD ligand and pulls the T cells, and cancer cells goes on proliferating. So some molecules are developed to block this interaction of this T cell with PD ligand on healthy cells or cancer cells. So they developed monoclonal antibody that either targets this or this. So when this interaction is blocked, what happens? That T cells will kill it. No? because when it sees the ID card of PD ligand, it does not kill. But when it does not, when you block this interaction, what happens? That it does not see the ID cards and it kills that T cells. So they thought that some cancer cells express this PD ligand. So why don't we develop some molecules that inhibits these interactions? And if we can inhibit these interactions, these T cells will kill the cancer cells and it will be useful for our treatment. So they developed monoclonal antibody. So some monoclonal antibody targets PD, some monoclonal targets PD ligand and tumor cells. So what are the molecules that targets PD? So pembrolizumab, nivolumab, cemiplimumab, and PD ligand, this is durvalumab, atezolizumab. Don't get confused with alemtozumab. This is monoclonal antibody against CD52. And this is the monoclonal antibody against PD ligand. So I sometimes got confused because the name is looking similar. Atezolizumab and alemtozumab. So durvalumab, atezolizumab, this is for PD ligand and these are for PD. These are monoclonal antibody. So similar to this PD ligand interaction, there is another molecule on T regulatory cells called CTLA4. Let me rewrite it. CTLA4. So you know what does this T regulatory cells do? It inhibits the inflammation. It suppresses the inflammation. So let's suppose this, it is antigen presenting cells. So it finds some foreign cells. So it engulfs some part of this and process it and express on its surface. And it presents to CD8 T cells. And then when it is presented to these T cells, then CD8 cells kills that antigen. But this T regulatory cells, what does this do? That this interact with B7 on antigen presenting cells, and when this interaction occurs, what does this do? It suppresses the antigen presentation to the CD8 cells, and when the antigen presentation is suppressed, then this won't kill this. That's why it is called T suppressor cell or T regulatory cells. And when you inhibit this interaction, what happens? This won't be able to suppress and this CD8 cells will kill with these foreign cells. So this strategy is also used in cancer treatment. If you inhibit this interaction of CTLA4 with B7, this hyperactive CD8 cells will kill the cancer cells. And there are some molecules developed for antibody against CTLA4, Ipilimumab, Tremelimumab. Okay, so that is targeting CTLA4. And the last antigen that I will be talking on this is LAG3. This is also expressed on T cell, and this LAG3 interacts with MHC2, and when there is interaction, it does not kill the cancer cells. But when you inhibit this immune interaction, what happens? That these T cells will kill the cancer cells. So there is one drug called Relatlimab that inhibits this interaction, and thus it kills the cancer cells. So these monoclonal antibodies, these are immune checkpoint inhibitors. So why it is called immune checkpoints? So at checkpoints they ask to show ID card to hepatocytes, to the cancer cells, but if you don't see that ID cards, it kills that. So when we inhibit this immune checkpoint, what happens that it goes on killing. It even kills cancer cells, it even kills healthy cells. That is the problem of this, because your normal cells, your hepatocytes, your GI epithelial cells also have PD ligand, not only cancer cells. So if you inhibit this immune checkpoint interaction, what happens that these T cells becomes hyperactive, and it will even kill the normal healthy cells, hepatocytes, GI epithelial cells. That's why toxicity occurs, because these T cells becomes wild. It goes on killing everything, every cells of our body. That's why autoimmune inflammatory reactions occur with these immune checkpoint inhibitors. That is the side effect of this. But in medicine, what we do, we generally do risk benefit analysis of any molecules that we administer. If it causes more benefit, it kills more cancer cells compared to the side effect, then we prescribe those drugs. So that's why these immune checkpoint inhibitors are widely used nowadays in cancer treatment, in head and neck cancer, in melanoma, in GI epithelial cell cancers, cholangiocarcinoma, hepatocellular carcinoma, small cell lung carcinoma, non-small cell lung carcinoma. These drugs are widely used, but the limiting thing is its costs. It is costly. And I told you that this, what it does, that it hyperactivates immune cells, so that T cells becomes wild, aggressive. T cell becomes aggressive and it goes on killing. So in cancer treatment, you see most of the time, I think you might have seen that steroids are used in chemotherapy. So we don't use immunotherapy singly, we combine with some chemotherapy like cisplatin or other drugs. And if we have used steroid along with that, what happens that steroid inhibits the T cells. So if you inhibit these T cells, this aggressiveness of these T cells will be gone. So it won't kill the cancer cells. That's why we don't use prednisolone more than 10 mg in case if we are using immune checkpoint inhibitors in any regimen of cancer treatment. So I call this immunotherapy also cytotoxics, because it is killing many even healthy cells. So it is cytotoxics to our even normal cells. But it is not that cytotoxic like chemotherapy drugs. So chemotherapy are very wild. It kills vast majority of cells in our body. And you know that this makes T cells hyperactive, hyperstimulates the immune cells. But those chemotherapy drugs, those even kills the T cells. So it makes the system immunosuppressed and susceptible to infections. And what does this immune checkpoint inhibitors do? It makes the system hyperstimulated, so that even kills our own healthy cells. Hyperstimulation, even hyperstimulation of immune T cells is not good, or suppression of the T cells is not good. But this is the side effect of the drug. What you can do? That's why they developed other molecule called targeted therapy, because we are seeing lot of side effects in the cancer treatment. So targeted therapy, what does this targeted, as the name implies, it targets wherever there is mutation. If there is mutation on the receptor on the cell membrane, it targets that. If there is mutations in the cytosolic enzyme, it targets that. So it targets those only, and that's why it specifically kills those cancer cells, and it does not cause much side effects, unlike these cytotoxic drugs. So what are some of the targeted drugs? So let's assume this is the biphospholipid cell membrane, okay, and on this there is receptor tyrosine kinase. And you know that when there is interaction, this dimerizes and the cell signaling goes, and inside there is phosphorylation and there is cell survival signaling, and it goes on proliferating. So some antibody targets this receptor tyrosine kinase. Like you know, there are variety of receptor tyrosine kinase like EGFR, VEGF, vascular endothelial growth factor, and So VEGF is, you know the drug bevacizumab, and you know this EGFR cetuximab. So this is monoclonal antibody, and another is inhibitor of this tyrosine kinase, like EGFR tyrosine kinase inhibitor, like crizotinib, erlotinib. So these are the receptor tyrosine kinase, and another is cytosolic tyrosine kinase, another is nuclear tyrosine kinase. Because let's suppose this is the cell, and this is the cell membrane, and this is the biphospholipid membrane, and this is the nucleus, and this is the cytoplasm. So there are some tyrosine kinase in cytoplasm, some tyrosine kinase inside the nucleus. So some drugs targets tyrosine kinase here, some here. So you know the BCR-ABL tyrosine kinase, like tyrosine kinase, like imatinib, dasatinib, ponatinib, nilotinib. This targets the tyrosine kinase produced by this translocation. There is another molecule called Bruton tyrosine kinase, that targets the tyrosine kinase of this, like ibrutinib, acalabrutinib. So it does not target this BCR-ABL tyrosine kinase, and this imatinib does not target this. So these are specific. So whatever translocations, alterations makes that tyrosine kinase, it specifically targets. So see how selective and how targeted are these targeted therapy. Thus there are least side effects with this targeted therapy. And you know that in cancer treatment, either a small cell lung carcinoma and non-small cell carcinoma, these targeted therapies are widely used. We send in all patients of lung carcinoma next generation sequencing to look for these driver mutations that is driving the cell proliferations. So what are some of the common driver mutations? Like EGFR mutations, Kras mutation, BRAF mutation, ALK mutation, ROS mutation, NTRK, RAT. So these are some of the driver mutations. Like EGFR tyrosine kinase is inhibitor by crizotinib. No, I mean EGFR tyrosine kinase is erlotinib and gefitinib. This nib is confusing because wherever there is tyrosine kinase, that's why I got confused here. This crizotinib of ROS tyrosine kinase, ROS and ALK is crizotinib, because these are all tyrosine kinase, and wherever you see nib, there it means that it targets tyrosine kinase. So this is also tyrosine kinase, this is also tyrosine kinase, this is also tyrosine kinase. So you have to take care of that. Whenever you see this nib, it means tyrosine kinase, and for specifically there are molecules for each one. Like EGFR is erlotinib, gefitinib, gefitinib, osimertinib, and for Kras is sotorasib. For BRAF is Dafrafenib, and for ALK ROS is crizotinib. And for this you don't need to know much, but what is the message of this, that in lung cancer, in a single patient, let's suppose one patient of non-small cell lung carcinoma or a small cell carcinoma comes to my office. So I sent next generation sequencing, and the thing is that in a single patient there is only one mutations, like EGFR mutation, ALK mutation, ROS mutations, or Kras mutations. Patient does not have multiple mutations, so there is only one mutation that is driving the whole cancer in him. And if we inhibit these driver mutations, with this molecule targeted therapy, the magic cure can occur. That's why this targeted therapy is becoming popular, not only in lung cancer treatment but other cancer treatments as well, because this has less side effects and it specifically targets that driver mutations to suppress the or kill the cancer cells.